Okay, good afternoon, everyone. I think we are ready to get started. Thank you for your patience as we worked through a couple of technical difficulties. Good afternoon and welcome. My name is Deighton, and I am the Director of Communications and Engagement at the Melanoma Research Alliance, and I will be moderating this webinar. We'd like to thank all of you for joining this MRA Meet Up. Be your biggest advocate navigating a melanoma diagnosis. It's the first in a series of webinars designed to engage, educate, and most importantly, empower patients and caregivers. Before we get started, I just want to go over a few housekeeping items. By joining this webinar, you understand that this will be a public event and recorded as a resource for others that will live on the MRA website. Portions may also be shared via MRA social media channels. The content should not be used as a substitute for professional medical advice, diagnosis, or treatment. Please consult your healthcare provider about any questions you may have regarding a medical condition. Please keep your line muted and other devices silenced should you come off mute to ask a question. And please be respectful of the experiences, opinions, and questions of others. To ask a question, please use the raised hand feature on Zoom, and we will do our best to call on you. And now it is my pleasure to welcome our panel, Dr. Evan Lipson, an internationally recognized skin cancer and immunotherapy specialist at Johns Hopkins University, Megan Schollenberger, a senior nurse practitioner in medical oncology at Johns Hopkins as well. She focuses on cutaneous malignancies, including melanoma. And Kelly McWhinney, mother of two and stage 3B melanoma warrior and advocate. We are so happy to have you all, and I'd like to give you each just a minute to tell us a little bit about yourselves. Dr. Lipson, would you like to start?
Yeah, I'd be glad to. Thanks so much for including me. It's a pleasure to be with all of you. I am a medical oncologist here at Hopkins, and I focus on developing new and better therapies for patients with melanoma of all stripes, melanoma that's been removed surgically, melanoma that has spread. So we try to meet patients where they're at.
Wonderful. Thank you. Thanks for being here. Megan?
Hi, I'm Megan Schollenberger. I'm a nurse practitioner, and I've been with the group going on almost a decade now. And I work with the multidisciplinary team to take care of patients who are being treated for melanoma.
Great. Thank you for being here. And Kelly, please tell us a little bit about yourself.
Hello, my name is Kelly McWhinney. Thank you, Dana, for introducing me, and thank you for having me today. Like Dana mentioned, I'm a mother of two. I have 3- and 5-year-old little girls, and a year and a half ago, I was diagnosed with metastatic melanoma and recently finished 26 rounds of nivolumab. And so I'm here today to be a patient advocate and to be the voice for everyone else that's sitting behind us today.
Awesome. Thank you, Kelly. We're so excited to have you. I just want to also add a special thanks to our MRA team, Renee Orsioni, our digital engagement and communications manager, and Yasmin Idrisi, who is our digital media intern, and they are here making the magic happen behind the scenes. So thank you both. So let's get started with a couple of questions. Kelly, since this webinar is really meant to be all about patients and for patients, I'm going to start with you. Once your initial diagnosis sunk in, what was the first thing you did? For instance, research, gathering data, seeking second opinions, things like that.
Yeah, so I think this is a really important question because these first couple of days can be quite the shock, right? So I often say the first thing I did was rallied my troops, whether that be friends, family members. You need to get your support system in place because it can be quite the shock. And so after that, I think it's really important to sit down and look at what you're facing and pick out a really good team. So whether that be your oncology team, whether that's your dermatologist, these people are going to be with you for a really long time. So finding people that you can speak to and fully trust, I think that's really, really important. So in those first days, find your troop, get the best oncology team that you can possibly find.
Yeah, I think that is so well said. I always say you can't do this alone. You have to have a team, but you need to feel like the team is working with you. Dr. Lipson, I'm going to throw that over to you. When your patients are in the throes of absorbing a very complicated diagnosis, what do you suggest they do to be best informed?
Yeah, much the same thing. I think you have to feel comfortable as a patient, having good communication with your team, and feeling like you can reach out for anything at all, little stuff, big stuff, and that the lines of communication are open. I encourage patients to talk to more than one healthcare professional. Seek second opinions, seek third opinions, really get a sense of what the landscape is. And you have to feel like you're in a place that's comfortable and that is that you're well taken care of.
Yeah, thank you. That's really, really important. Kelly, did you consider pursuing additional opinions, and how did you go about doing that, if so?
So I did not, because I originally had my melanoma on my back removed, and that it came back metastatic a year later. So things felt very urgent at that time. And I fully trusted the oncologist that I had been highly referred to. And I didn't take that decision lightly. Actually, I seeked out several different people and found the one that I thought was probably going to be the best fit for me. And from that point, I got referred to a surgeon. So I also really felt comfortable with the surgeon. I asked a ton of questions, and I didn't really feel the need for a second opinion because I think that the team that I was given was so strong.
That's really great to hear. Well, you touched on, knowing exactly what you had to deal with, but not everybody always does. And in the throes of these diagnoses, data is so very important to, making sure that, your path is getting kind of set up the right way. Dr. Lipson, can you briefly give us an overview of what type of diagnostic testing might be going on, and what are the different reasons for using different tests?
That's a great question. It's pretty broad, actually. So I think it really depends on exactly what the situation is. In some people, where we're thinking about therapy after melanoma surgery has been performed, there are certain tests like tumor genetics that are really important. And then there are other situations, like in patients where the melanoma has spread, where certain imaging studies, like a brain MRI, for example, might be important. So it really kind of depends on the situation. And I think one of the most important questions that patients can ask their teams is, what else should we be thinking about that we haven't already tackled? Are there additional scans that we need? Is there additional blood work that needs to be done? Are there opportunities for me to participate in studies so that we can make some of the testing better?
Great, thank you. Kelly, can you tell us if genetic testing was offered to you, and did you pursue it?
Dana, so I think this is a complex question, and I think I was a little bit confused as a patient going into this. Yes, I gave tons of vials of blood, sat through many different scans, but as a patient, I felt really uninformed of what I was actually doing at that time. So I didn't really know if I was going through genetic testing, and recently found out that I was. And so I think that as you're getting diagnosed, informing yourself on that part of the diagnosis as well is so important, because you don't really know what you're doing. You're just sitting there, you're getting all this blood taken, you're sitting through the PET scan, the MRIs, the CTs. And so I think that knowing what you're actually doing is really important as far as advocating for yourself, because I was being tested for those genetic traits and I didn't even know it.
Great, thank you. Dr. Lipson or Kelly, or excuse me, Megan, do you want to share a little bit about what genetic testing might expose?
Yeah, so this is a conversation we have with a lot of our patients, because genetic testing is also broad and can mean a lot of different things. So there's genetic testing, which is specific for melanoma, that we do when we look at mutations within your tumor. These are not the mutations that are passed down generation to generation, but they are specific to your tumor. They are the mutations that are driving the growth of your tumor. And one of the hot mutations we see, and you probably may have heard about in melanoma, is the BRAF mutation. And if you have the BRAF mutation, it opens up a door for additional FDA-approved therapy, BRAF and MEK inhibitors. There are other mutations that we will commonly and uncommonly see within these tumors, that it's very nuanced what we decide to do with them. There's clinical trials you may pursue. There's some off-label treatments, but the big one is the BRAF mutation within the tumor, and I think that's what Dr. Lipson was alluding to in terms of opening up doors for standard of care treatment. Then there's also the genetic testing that looks at the genetic mutations within you that are passed down from generation to generation. And most of the time, melanoma is a diagnosis that occurs when families share the same vacations, the same light skin coloring, blue eyes, but occasionally we see a genetic germline mutation that's passed down from generation that it puts an individual at risk for developing melanomas. So we think about genetic mutations from that testing from that standpoint when somebody says that they've had 3 or more melanomas, or there are multiple melanomas, 3 or more melanomas on one line of the family. And so it is a discussion that we have commonly. And if you are wondering, has this been done? You should ask, has genetic testing been done on my tumor? And should I be getting germline genetic evaluation with an oncology genetics team? If you have any questions about it.
Great, thank you.
Never hurts to ask.
Yeah, for sure. So we've talked about all of these different diagnostic tools and different genetic testing. I think all of these become functions of a treatment plan that you and Dr. Lipson start to put together. Can you tell us a little bit about how your role as a nurse comes in here when explaining some of this to the patient?
So I work as a nurse practitioner, and I see patients alongside and with Dr. Lipson and the rest of our team. And I think it's important to know that every practice, Hopkins, Georgetown, I'm just naming, Nova, all the oncology institutions in our area practice just a little bit differently. So everybody has a little bit of a different role. So I often do a lot of teaching, but our nurse navigator does that as well. I help with the diagnosis process. I help ordering scans. I help guiding the patient through treatment decisions, similar to Dr. Lipson, but I also am the person that hears most about side effects that people may be getting from therapy. I'm often the first line for handling side effects. But I think the key here is everybody's going to be at a different, you may be at a different location. And so I think it's important to ask your team, what is your role, and who do I contact in the event of an emergency, and who is on my team? And understanding the roles of everybody on your team. So who to ask what questions to, who to go to for support, who to call when you need something.
That's great. Thank you. And I think it's safe to say that all of you kind of behind the curtain at Hopkins, whether you are a nurse practitioner, a physician, a social worker, a nurse navigator, you're all communicating, hopefully, and the patient can have, a great deal of comfort knowing that you all are working towards the best possible outcome there. Let's move ahead maybe and talk about clinical trials. Dr. Lipson, can you tell us a little bit about why this option might come up to some patients when you're discussing treatment plans, and how can patients be empowered to do their own research to make sure that they are aware of all of the options, both in clinical trial land and outside?
Clinical trial land.
Yes.
Yeah, that's an interesting land to be in. So the last about 15 years or so, we have really seen the acceleration of development of therapies because of the brave patients that have participated in clinical trials. These drugs that we are now using as standard medicines for patients with melanoma, they were developed by folks just like you guys who were participants in clinical trials, and we saw that these medicines worked, and here we are using them again. So it's really crucial that this research continue. We're improving therapies year by year by year. There are some cases where it is wholly appropriate for somebody to be involved in a clinical study. And I think it's important to have a conversation like that up front. The question you might ask your oncologist, your oncology team is a clinical trial appropriate for me at this time? And if not, why not? And when might it be? And then there are other times where a clinical trial is probably not the thing for you. Some of the really effective standard medicines are oftentimes the first things we turn to. But it's important to keep those things in mind as the progression continues, that clinical trials are sort of always in the background.
Okay, great. Thank you very much. That was very helpful. Kelly, I'm going to send it back over to you. As an oncology patient myself, I know how limited clinic time can really be, and you sometimes feel like you don't get to discuss everything. You come in with your notebook, your questions that wake you up at night, and still somehow, like, you might leave feeling like, oh my goodness, I forgot to bring this up. Can you speak a little bit about some of those moments that you may have had, and if you were able to talk about all of your side effects or other parts of your journey, even if they weren't necessarily medically related, like perhaps you had questions about insurance or caring for your children or things like that. How did you go about getting all of your kind of midnight questions answered?
Yeah, so I think this is a really loaded question and it comes in a bunch of different parts here. So I had a notebook and I never went to an appointment alone. And I think that was something that was really big for me because I would kind of get this feeling like, okay, I'm overwhelmed. I'm kind of like blacking out during these appointments because it's information overload. So I would write down the questions that I would have going into each appointment. And whether it be my husband or my mom or my sister or whoever it was going with me to that appointment, they would take notes the whole time. They would make sure that the questions were addressed. They would ask questions that maybe I had mentioned to them on the way there. But that was kind of how we got all of those questions out of the way. And then I could refer back to them later because heck, I wasn't going to remember what the oncology team just said
Yep.
to me. So I think that's also really closely related to the communication that you have with your team and knowing who can answer what questions. So whether it be your nurse navigator, the nurse practitioner, or your oncologist, knowing who to call for what. And I think that goes hand in hand with side effects. So sitting through these treatments, I went through 26 rounds of nivolumab, and I had a really hard time with treatment. I had some very, what they call rare side effects. I developed type 1 diabetes, thyroid disease, and a slew of other just autoimmune disease along the way. And it became so overwhelming for me as a mom of very young girls at the time. And I think that sitting there and compartmentalizing it was no good. I had to know who to contact, what to do. I then had a whole list of contacts for specialty doctors, and it gets so overwhelming. So back to the notebook. Who's asking what questions when we're going into these meetings? I can look back and say, oh, I had my PET scan on this date. This is what it showed. I think just staying organized, knowing who's in your contact list, feeling comfortable with them, and making sure you know who to ask what questions to is just the most important thing.
That's so true. Very, very helpful advice. Thank you. Megan, I'm sure you've heard it all, from like the run-of-the-mill side effects to the very rare ones that Kelly has experienced. Can you tell us a little bit about how you help patients manage those and sort of how you triage them and figure out, like, what's really the most important, as far as reacting to first?
Yeah, well, first I tell my patients that their job as a patient is to notify me of new side effects, because and not wait. Don't, if I have an appointment with you in 2 weeks and you develop diarrhea, don't wait 2 weeks to tell me. Use the triage line that, the nurse triage line that I give patients out to give us a phone call, and somebody's going to get back to you. So, then it is my job to know what to do about it and to guide you about what we do about this new side effect. So I tell them, report it as soon as something happens. Think about how you're feeling now and report any changes. And then it's my job and our team's job to help guide you through how to go about managing whatever side effect you are reporting. So it is a partnership there. And then that comes into play. What I talked about earlier is knowing who to call, kind of knowing when to send a MyChart message, knowing that these MyChart messages, take sometimes 24 to 36 hours to get through the system, versus the triage call just is a couple of hours. So I've seen kind of the whole gamut of side effects, including some of the ones that Kelly mentioned, type 1 diabetes. And the key is early recognition of a side effect. so then we can move forward with managing it. And then having somebody on your team that, getting into a specialist, and we do need specialists, sometimes, managing type 1 diabetes. We bring in our endocrinology team, managing colitis. We often bring in our gastroenterology team. And sometimes the wait could be months from an outpatient perspective. So many times, I'm emailing, or nurse navigators emailing specialists to ask for either advice about what can I do to get the workup started and treatment started, and can you see them earlier? If I guess from a patient perspective, and what I've experienced as a patient myself, not in the oncology world, and where I've seen patients have success in getting into, if they want a brain MRI earlier, a PET scan earlier, a visit with a doctor earlier, there are always cancellations. Give those imaging centers a call every day. You have a cancellation today? Do you have a cancellation today? And I think I've seen a lot of patients have success with that. And then, but have a team, make sure your team's working from that angle for you as well. So.
Thank you. You're like touching on a couple of things that I think are so important. Persistence, and it never hurts to ask. You just never know when it opens a door. And I always suggest that patients do that. Interdisciplinary teams, super key, just knowing that you're getting different perspectives on the same problem, and should always ask if that's what is happening behind the scenes. If you're a patient, I'm sure it is, but you probably want the comfort in knowing that. And then, and this kind of leads into the next thing, community. You can't do this alone, as Kelly said, and you really need to know
If they
that
are passing, I did a good job. So it needs to be.
I think we're having a mute problem. Okay, I think we're okay. So community, everybody really needs a sense of community, because this can be a very isolating place when you have a diagnosis like cancer, especially, a pretty difficult, complex melanoma. So Kelly, did you seek community or advocacy groups for support?
I certainly did. And I think that this was really big for me, because when I was first diagnosed, you kind of feel like one in a million. You feel like nobody's going to be able to relate to this. I don't know anybody who's been through anything like this. So I think it can be really isolating feeling until you reach out. I think you need to look for groups. You need to look for a partner in this. And I would also like to offer to anyone listening, or anyone who may listen to this recorded, Renee, I don't know if you'd like to put my email address and the contact information on the chat there, but for anyone who does feel isolated, I think it's so important to find someone who can relate to you, whether that be from just side effects or just questions to ask your oncology team when you're going to sit down. I think it's so important, because you don't want to feel alone. There are so many other things you're about to face, but loneliness isn't one of them. And feeling unprepared is certainly not one of them either. So looking on Facebook, there are groups out there. Looking for different people on Instagram who may be able to relate to you, that's there. The MRA also offers a ton of different resources to meet people who have been through the same thing, if not very similar to what you have been through. And I would really encourage anyone out there who's hesitating, reach out, because I promise you, you're not alone. Even though it feels like you are most days, you're not.
Absolutely. And you never know what other people, may have already been through that could help you. Just asking the questions and finding out, if they had similar experiences, or different ones for that matter, actually might help you navigate the next steps. You might not fall into the same pitfalls, or you might be able to expedite something just because of the advice they give you. I will share that the Melanoma Research Alliance does have the Melanoma Exchange. And you can go to our website, look up Melanoma Exchange Community, and you'll be able to join there. And we've got over 10,000 people in this community who are there and ready and willing to help, provide support and answer questions, things like that. So we always encourage that as well. So we've covered a lot about, receiving the diagnosis, setting up the treatment plan, getting different testing, asking questions, finding communities, and so forth. But what happens kind of at the end of treatment, where hopefully you're doing quite well, there's no evidence of disease, but obviously it's something that you don't walk away from easily, and you're probably always going to have some level of anxiety, wondering, am I really okay? And what happens over the next year or 5 years or 10 years? So, Dr. Lipson, can you talk to us a little bit about, a roadmap for, continued surveillance and a survivorship care plan and what that might mean?
Sure. Yeah, the survivorship plan differs a little bit based on what the previous course has been. So for patients where the disease has already spread and we're watching people really, really closely after they've had a therapy, we tend to see those folks more frequently. We get scans more frequently. Oftentimes we get blood work to see if there's been impacts to internal organs and things like that. For patients with disease that has not spread, we're seeing those patients less frequently. But the bottom line is that, as you said, you really do want to be able to stick with your team really forever. We don't typically graduate folks from our clinic. We see patients for life. And so that sort of relationship where you can continue to be surveilled on into the years, that's important.
Yeah, that's really great. I find that comforting too, because people get to know you so well and they understand all of the different little nuances of your case, which you just can't take somewhere else very easily. So it's nice that you all continue to see patients like that. That's really great. So Kelly, Megan, Dr. Lipson, anything that we didn't cover that you would like to bring up before we open it up to questions? Nope. Okay, Kelly, thank you so much for offering your email address. I know as a patient myself how valuable and important that is. We really appreciate that. I see Renee put your address in the chat, as well as a link to our melanoma exchange community, so please use it. Right now, I'll open up the floor to any questions or ask Renee about any that came in during the registration. Some people, I believe, did ask a few questions.
Yeah, so we did receive some questions with registration. However, I do want to give everyone here an opportunity. I can see a few people on video now. If any of you have a question, raise your hand, come off of mute. Anybody who's not on video, also, if you want to come off mute and ask a question of our presenters, that would be awesome. But I can kick it off with a question that somebody sent in with their registration, and it does kind of touch on the last question that Dr. Lipson just answered. But I think I'd love to hear either Kelly or Megan's perspective on this. So when a patient is at that stage where they're, in between skin checks, in between scans, because they've been deemed no evidence of disease, are there any other ways that they can be proactive, whether it's, caring for their mental health or, advocating for awareness or being sun safe? I'd love to hear what you all think.
Happy to address this one from a patient standpoint because I think that you touched a bunch of them, but I think it's really important to do your monthly skin exams. Every time you're getting in the shower, look at your body. You're more familiar with your body than anybody else is. So look at it, feel for lumps and bumps. If anything feels off, I think that communication to your provider is really important. Being safe in the sun and using sunscreen is obviously very important as well. But I think, again, that communication, don't drop it. I often felt as we were approaching the end of my treatment that I was going to be kind of lost in the shuffle. And I think my oncology team has done a really good job of not letting that happen. So I'm still being seen by them very frequently, but making sure that you're attending those appointments, getting your scans done, doing everything that they're recommending. It's so important because we're really trying hard to prevent reoccurrence. So doing these things is just extremely important. Also, if you need some help afterwards, because I know after treatment can also be very hard mentally on people, seek a therapist, seek some help elsewhere.
Great advice. Thanks so much, Kelly. Renee, any others?
Yeah, we did have a question more for Dr. Lipson here, and it's kind of a general question, but one of our participants was interested to hear about any exciting research that is on the horizon that you might have your eyes on for, patients who may be more late stage or their disease may not respond to first line.
Yeah, great question. There's a lot of exciting research going on right now. One of the trials that's perhaps best known is a combination of an mRNA molecule. So they take a patient's tumor out of the body, they look at the genetics, the fingerprint in the genetics, and then they make an mRNA that helps the immune system recognize what that tumor is going to look like. So that study right now is in process. We're trying to understand whether that vaccine, as they call it, that mRNA molecule is going to be helpful. So that's on the horizon. I think there are a lot of other exciting opportunities. It sort of depends on exactly what each patient has had so far. Lots of trials require that you have or have not had a particular therapy. So it's an opportunity to get with your oncologist and say, all right, here's where we are. What does the trial landscape look for me at this point? I've had therapies 1, 2, and 3. What do I qualify for? What are the early data? Help me figure out what to do next on the trial scene. And oftentimes it takes visiting a couple of big academic centers to really get a sense for what's out there. Not every big center has the same trial. We're all looking at it a little bit differently. So sometimes I'll encourage patients, go to a big center that's 30 miles south of us and ask what they have. Talk to an investigator who's in a state next door, figure out what's going on over there.
Great, thank you. I think it also helps if you just, if you are up to it, dive into some research yourself. It might bring up some questions, even as lay people, sometimes you discover things, that have been published that are worth asking that can really help the dialogue that you have with your physician. And it helps you to stay involved too. So anything else, Renee?
I'm going to see if anybody else has been inspired to ask a question after hearing these ones from registration. Anybody want to jump in here?
I do have a question, if that's
Awesome.
okay. Can you hear me?
Yes,
you can.
Okay, hi, my name is Amy. This couldn't have come at a better time. I was diagnosed with melanoma on Friday. I've had many squamous cells and all that over the years, but this is the first melanoma. I have, up until early, right, of course, when this call started, I had no communication from my health group, except for the call from the PA on Friday to let me know it's only stage 1B, thankfully. But at the same time, I found the spot myself on, a month from today. It was October 20th. So it's been a month, and that took them 2 weeks to see me. Then it took them a week and a half for the biopsy to come back. So all that to say, my question is, it's 0.8 millimeters. I have a choice to make today, and I think that you all could maybe help me. My health group does not have a surgeon who specializes in melanoma. They have referred me to what they say is their top surgeon, general surgeon. He does oncology, but melanoma is not necessarily his specialty. But of course, he's removed melanomas, I'm sure, many of them. Or they are willing to refer me out of network to UC San Diego, which is a NCI cancer center, designated cancer center. So being that I'm early stage, I hope it has not advanced. I'm really hopeful that it has not, but it has already been a month since I identified it, and they're taking their time seeing me. So my choices are, I could see this non-specialized general surgeon tomorrow at 12:30, or I have a second opinion video visit today with UC San Diego, and I don't know when they can get me in. I could, but my network is willing to refer me out. So just wanting to see what your gut reaction would be in a choice like that.
I mean, I can kick it off from a patient standpoint. I would probably take both, to be honest with you, because more data is better. So see what they say tomorrow, but really get the wheels.
Do the surgery.
Oh, it would be the surgery. Okay. I'm sorry, I misunderstood that then. I thought it was a consultation. I don't know. I'll let the professionals on the line comment there. I have a bias towards academic centers with special.
So why I used to work at American Cancer Society, and I worked within the cancer centers. Yeah, I do too.
So yeah.
Yeah. Does anybody else have?
Again, you want to?
I guess if you have the video visit today, I would join the video visit.
I am
not cancel the surgery. And then if you feel uncomfortable, like if the recommendations differ so much, but I don't think there's any harm in joining the video visit consultation today. And maybe they just will confirm the plan and then you can move forward and feel comfortable.
Yeah. And I think it's probably fairly textbook with the stage that it's in, not complicated, but I don't know. I didn't know if there were any strong feelings about you should definitely see a surgeon who specializes in melanoma.
So, Amy, one of the things that happens near us, we're on the East Coast, but what'll happen oftentimes is that we'll get asked to render a second opinion, and the patient has seen one of our colleagues in a local center. And we know a lot of the players out there just because it's a relatively small community. And so more often than not, the patient will say, I was diagnosed with a melanoma, and Dr. So-and-so, who is 5 minutes away from me, plans to do XYZ tomorrow. And we'll say, well, we know Dr. So-and-so well. We share patients all the time. You're in excellent hands. I recommend proceeding with that surgery tomorrow. We'll see you in 6 weeks for follow-up, and we'll talk about what's next. But we trust the person that you're seeing.
Okay. Yeah. So probably my consultation with UC San Diego will help this out.
It may, as Megan said, I would go ahead and do that and see what they say. And you might find that, you feel comfortable.
Yeah. Okay.
Thank you, Amy. We wish you the best of luck and thank you for sharing. We hope you'll join us in the future, and just wish you the best for sure.
Thank you so much for holding this. So helpful.
Yes, of course. I see we had a question come in the chat from Susan. She said, is there a way to proactively prevent, decrease any side effects? Also, I had a colonoscopy scheduled in the midst of my evaluation, an incidental finding of metastatic, a lung nodule, 9 millimeters, Castle testing 1A, wide resection in July 2020. Can I proceed while undergoing immunotherapy? Looks like you're due to start Keytruda next week for 3 cycles. So, Dr. Lipson, do you want to respond to that?
Is there a way to proactively prevent
cancer or the melanoma that's metastatic? Like incidental finding of metastatic.
Susan, are you online to respond? I think you're on mute.
I just wanted
to. Sorry for that. I have a dog barking. Sorry about the abbreviations. I'm an RN by background, so I'm kind of used to that. I was more concerned about the side effects of Keytruda while on immunotherapy, and because it can be somewhat inflammatory, I didn't know how to put a colonoscopy on top of that, but it has been 10 years since my last colonoscopy. So just combining all of this, I was a little bit concerned.
Okay, got it. Sorry. The colonoscopy hasn't happened yet.
It was scheduled for the same day as I had my consultation with a provider at Mayo Clinic here in Phoenix. So we went ahead and canceled that.
What I tend to tell patients kind of going through treatment is that the immunotherapy does not lower your immune system. And so you're not at increased risk for infection or surgical complications. So obviously ask your medical team and your surgical team, but I don't tend to think that surgery or colonoscopies for your screening are contraindications. However, sometimes when melanomas becomes the top of your list and things to deal with, like a screening colonoscopy becomes lower. And so just having that discussion with your healthcare provider team of risks, benefits of moving forward now versus do you wait till the water's calm with the melanoma before going forward with just general screening? And I don't know the answer to that based on your risk and your history. Totally. But typically, we don't think surgeries are contraindications while receiving immunotherapy. And then I don't know if you, just Dr. Lipson, I don't know if you disagree or.
Yeah, I agree. We typically encourage our patients to follow up with all of their usual stuff. Our patients on Keytruda often get colonoscopies because we need to know what's happening because of a side effect. So I agree with Megan. I would ask your medical team specifically about your situation, but in general, colonoscopies and Keytruda play well together.
Okay. And anything that I can do proactively prior to initiating Keytruda to kind of lessen potential for side effects?
No, but as Megan said before, keep in touch, keep in touch, keep in touch.
Thank you. Oh, I see we have a comment from Ken. Side effects of Keytruda are often a mixed bag, or unfortunately a mixed bag. So I guess we're all individuals and, we just don't know what to expect, but.
I received a message from Mary. I'm going to ask her to unmute right now. She's going to ask a question.
Hi, Hey. I've had melanoma stage 1 2 times in the past 2 years. I also have, my doctor's diagnosed me with dysplastic nevus syndrome. And so basically I feel like I have a wide local excision every time I go get biopsies because I generally end up with a atypical moderate to severe. I'm just curious if you have any experience with that because I do feel like a lot of my team doesn't because I feel like it is kind of like a smaller percentage, but it also obviously gives me the my reoccurrence rate is more. So it's just a weird state to be in. And I'm always just like trying to look for anybody that has experiencing patients like that.
Yep, we do. We see quite a bit of that. Dysplastic nevus syndrome, you're right, does put you at increased risk of developing melanoma, fortunately, throughout your life, basically. We typically recommend that patients see a dermatologist who has experience with this condition, probably quarterly, generally for life. So if you feel like the team that you're with right now just kind of not in their wheelhouse, it probably behooves you to find a team that is really familiar with this sort of thing.
Do you have a suggestion of how to go about getting that information of some teams? Like I'm willing to travel. I live in Nashville, but we have I've seen multiple dermatologists, although my oncology team, I feel like they're really good at it. I think the dermatology piece is the piece I feel strange about, but would love.
I wonder, so MRA might actually, I wonder,
yeah.
Dana or Renee, does MRA have a resource where you can log on and find experts near you?
Yeah, it's funny that you should ask. We don't exactly have that right now, but we do want to put together something like that, like centers of excellence. However, Mary, let me pop my address here.
Yeah, that's cool. I'm friends with Stephanie too. Like Stephanie knows my. Okay. There's actually like a group of us online on Instagram that all are in this little dysplastic nevus kind of group, and we bounce stuff off each other. But yeah, I would. Yeah. As time goes by and it keeps happening,
absolutely. Yeah, we can help you find some support there for sure.
Okay, thank you.
I see another question came in for you, Dr. Lipson. What is an investigator that you mentioned for clinical trials at a hospital other than mine? Where might I find such a person?
Typically at the big academic centers. So like I'm at Johns Hopkins, that's a big center that does a lot of research. Near us would be Georgetown University. Up a little bit north would be University of Pennsylvania. So it's like the big name, cancer centers that you might have heard of.
Okay, thank you. And
I'm going to jump right in. So sorry to interrupt, but I want to address that real quick. For the individual who asked this question, I'm going to drop in the chat a link. MRA has a clinical trial navigator where patients or caregivers can enter in or answer specific questions about their disease and their location and match them to trials in their area. And that's a great starting point for a lot of patients. So I will drop that link in the chat and encourage you to check it out. And back to Dana. Thanks.
Yeah, thank you, Renee. Great call. I'm glad you added that. Kelly, there's a question for you. Why Opdivo over Keytruda in your case? And was your therapy neoadjuvant or adjuvant?
So I was actually offered the decision between Opdivo and Keytruda, and I was very uninformed about both of them. And so I kind of asked my oncology team some questions about what they had seen as far as results from both of them. And my oncologist had more experience with the nivolumab than he had the Keytruda. And so that's why we went that route. Whether that was the ideal route or not, I don't know, but I'm here and I'm doing well. So I think that was a good choice on our part.
That's great to hear. Are there any other questions? Oh, there is one. Kristen, hi. Yes, please go ahead and come off mute, Kristen.
Sorry, I was hitting the wrong button.
That's
Hi,
okay.
I'm
Nice to see you.
Thank you guys for everything. This is very informative. I'm currently stage 4 and I'm not responding to immunotherapy right now. And so I wanted to ask specifically, I've read about the mRNA. Now, is that different than TILs? Are they two different and like two different things going on? My doctors have mentioned potentially looking at the TILs. So I just wanted to get kind of clarification what if there was a difference and what the difference was with that.
They are two different things. mRNA is a molecule that's created to help your immune system recognize cancer. TIL is a procedure where they take a tumor out of you and then they use the little immune cells that are inside that tumor to make a new medicine for you.
Okay. With stage 4, where it's spreading pretty rapidly, any suggestions you have in terms of specific clinical trials that you're aware of, or?
Well, TIL is FDA approved. So if that is an option for you, you won't need to qualify for any trial. You can go to a center that offers that therapy and just get onto that as a part of standard care. You could pursue clinical trials, and I would encourage you to talk to your oncologist about what is out there at the moment. But in terms of just access to therapy, TIL is a pretty easy one because, as I say, it's FDA approved and it's available sort of nationally.
Okay. I didn't know if there was just one specific trial that you were familiar with that you would suggest to look into.
Gotcha. I think if TIL is an option for you,
Gotcha.
that's got some pretty solid data behind it. So I might start there, but I think a conversation with a big academic center is probably a good idea.
Okay.
Yeah. Great question, Kristen. Thank you for asking, and we wish you the best in your exploration and finding the right option.
Thank you.
We're getting down to the last few minutes, but we do have another question from Deb. Are you aware of any trials for mucosal melanoma?
Yes. Yes. The genetics of mucosal melanoma are a little bit different than the genetics of the skin melanoma. And so absolutely, there are trials out there that are looking at various ways to make those tumors shrink that might be a little bit different than what we're using for the melanomas that start on the skin. So here again, it's a good opportunity to get with a melanoma specialist who works at one of these big research centers and say, all right, so what's out there in the landscape for patients specifically with mucosal melanoma?
Great, thank you. Yeah, we know that one is a difficult one and not as often diagnosed. So thank you. Another quick one. Question about the checkpoint inhibitors, Braptovi and Mektovi, if there is time. I'm not sure what the question is. Are you asking about
I can ask it if that's okay. So I know these, at least my understanding, that they were thought of as kind of drugs that buy us time, and that typically like stage 4 patients will respond really well to both of those, but that it's not something that will lead to sustained remission. And some of the conversations I've had with my oncologist is that there's some thinking now that if you take them for a shorter amount of time, that maybe that bypass mechanism that the cancer that would be less likely to develop resistance over time. I'm just curious if y'all have any thoughts in general. Is it still thought of as a very short-term solution, or is it something to where we're exploring ways to beat that resistance that melanoma builds up to those?
Megan, did you want to say anything about?
There's recent data that's been published that shows that giving immunotherapy up front could be Nivo combination in the metastatic setting before giving BRAF and MEK inhibitors. it improves over versus giving ipi-nivo immunotherapy up front until progression and then switching to BRAF MEK inhibitors versus starting with BRAF and MEK inhibitors until progression and then switching to immunotherapy. The people who start with the immunotherapy do better. There's an additional smaller trial that shows that people who get a little bit of BRAF MEK inhibitor, for just a little bit of time, 8 weeks, and then move on to immunotherapy, also do well. But I think the data is pretty strong out there that's saying in the metastatic setting, starting with not waiting until BRAF progression of disease on BRAF MEK inhibitors is doing immunotherapy up front. Or if you're going to do BRAF MEK inhibitors, just do it for a short amount of time and then switch to immunotherapy improves overall survival. I don't know about short term and then also for BRAF and MEK inhibitors, they work very, very well, often for a short period of time. So the tumors become smart and often learn another pathway to grow in a matter of sometimes months, 7 months. There's a small population that continue to respond to BRAF MEK inhibitors for years. But we often look at this as a short-term solution because the melanoma, the tumors get smart and learn how to grow around it. So if somebody's on BRAF MEK inhibitors for metastatic disease, we're often not trusting that this is going to give you the years of tumor control that you want, and we're looking for other options. I don't know. And that, however, it's a different story in the adjuvant setting. There's no clear data in the adjuvant setting that immunotherapy with is better than BRAF MEK inhibitors or vice versa. I don't know if that answers your question.
Yeah, I think it does. I had like the Yervoy Opdivo combo already, and we're just deciding at this point whether to add on top. We've gotten to stable disease and trying to decide whether to add the BRAF MEK inhibitor at this point or kind of monitor and see. And so it'll help me formulate what the best path is if I understand if it's like truly just a very short-term fix or not. And so I wasn't sure if, there's ways that we're trying to figure out to sustain some of that response that seems to be so.
I guess my advice there is if your team is pondering, and Dr. Lipson and I ponder sometimes too, like the road forward is a bit of a gray zone. We ask for help from colleagues. We send patients to Memorial Sloan Kettering or Georgetown or Inova, UPMC, somewhere around locally. And because when the path forward is a gray zone, medicine's at that point becomes an art, not a science. And so seeking a second, if your team's pondering something, they might, and you might appreciate a second opinion. This would, in this case.
Yep, and if you get to the point to where just on second opinions, if there's a split decision, I guess you would just add a third.
Yes, it depends on how much time you have or what you feel comfortable with. And then, it's important for those teams to talk together because sometimes there's a difference in opinions and we go, okay, well, that makes sense. I see where that goes. So let's try that. So, if you're seeing a melanoma specialist, most people know each other and can communicate via email, and they should be doing that for you. But I think there's I don't think in many of your cases where you're looking for clinical trials and your team's pondering about what to do next, second opinion's not going to hurt.
Yeah. Well, I think we're about at time. I see Deb, you did ask about finding clinical trials in Canada. I know some trials do recruit internationally. I would still suggest you check out our clinical trial navigator online and on the MRA site. And if we can be of further assistance, we will certainly try. Just get in touch with us. We really want to thank everybody for joining us today, for asking really, really thoughtful questions. And especially big thanks go to Kelly, our patient. You show bravery all the time, and certainly today by putting yourself out there and sharing your experience. Megan and Dr. Lipson, thank you for sharing your compassion, your expertise, and your time with us. We really, really appreciate it. Renee, thank you for getting us all set up, and Yasmin for helping us organize too. Renee is going to drop a link to sign up to our newsletter in the chat. And this recording will be available on the MRA site and will be linked to our newsletter coming up. So it'll be there for you. Please feel free to reach out to me with any questions or ideas that you might be interested in for future webinars. We would love to hear from you. And again, thank you, everybody.
Thank you. Good to be with you all.
Thank you.
Thank you all.